to introduce our speaker today, Dr. Susan Sklar. She is the founder and medical director of the Sklar Center for Restorative Medicine. After a 25-year career as an OBGYN, she started a second career in the field of anti-aging and restorative medicine. She knows she has some explaining to do as why she, in particular, is here today at the American Dental Association. She started the Sklar Center for Restorative Medicine 6 years ago as an answer to the unmet needs of men and women who want to feel good in midlife and maintain long-term health. She implements a perspective of restorative medicine, which recognizes that hormonal and other biochemical deficiencies cause humans to age in ways that are not necessary or inevitable. Replacement and balancing of these natural substances result in improved vitality and a longer, healthy lifespan with less chronic illness. She sees private patients at her center in Long Beach, California. I'd like to introduce Dr. Susan Sklar.
Thank you. I'd like to thank the American Dental Association for inviting me here, and to Dr. Portwood, my local speaker host. I also want to thank a couple of other people. One is Dr. Robert McBride, who I call my professional soulmate. My real soulmate is my husband, and he's here, but Dr. McBride is my professional soulmate. He's a holistic dentist who recognized that what I was putting together around burning mouth and burning tongue was significant enough to be heard. And so the first place that I ever spoke about this at a dental meeting was at the California Dental Association last year. How many people here have encountered a patient with burning mouth, burning tongue? Just about everybody. How many people have been successful in at least partially alleviating the person's distress? About maybe half of you. How many have been successful in completely alleviating their distress and their pain? Nobody. It certainly is a devastating illness, and it affects millions of people. There's no question about it. I want to read you something. This is from the California Dental Association journal from 2006. Imagine the frustration of having a continuous painful disorder that cannot be definitively diagnosed with any known test or x-ray, interferes with eating, becomes progressively worse with time, has no known cause, and for which there is no highly effective treatment. This is what patients with burning mouth syndrome deal with every day of their lives. So, judging by the hands here, people see that this is a problem, needs to be addressed. So, I know I have a little explaining to do about why an OBGYN is here at the Dental Association, so I thought I'd start out with some explanation. I am a fellow at the American College of Obstetrics and Gynecology, which I became a fellow 30 years ago, and in the meantime they changed the name to the American Congress of OBGYN. But anyhow, I'm still a fellow. The things that I would say are similar between gynecologists and dentists is, you know, we deal with mucosal linings, right? Some of them estrogen sensitive. We deal with similar diseases. We deal with lichen planus. Behçet's affect both the oral cavity and the vaginal and vulvar mucosas, and some infectious diseases like herpes and candidiasis. And then we both encounter the same difficulties in trying to get patients to open ever wider so that we can do our work. As Dr. Portwood mentioned in his introduction, after a long career in obstetrics and gynecology, and quite frankly getting burned out on the insurance model of medicine and trying to see 30 patients a day and provide them with adequate care, I know this is probably ringing a bell with some of you, I decided I had to do something different. And a colleague introduced me to the whole field of anti-aging medicine. The largest body that trains doctors in anti-aging and regenerative medicine is the American Academy of Anti-Aging and Regenerative Medicine, where I did my fellowship. So I want to tell you a little bit about anti-aging and regenerative medicine, and I was speaking to some of you before this talk started. It's important for you, your patients, and your family, long-term health, to know that this field exists. Conventional medicine, and goodness knows, you know, I was in it for decades, looks at aging when it happens as what, oh well, you know, what do you expect at your age, right? Have people heard that from their doctors when they come up with a problem? It's expected that as we age, things are going to decline, and doctors stand helplessly by, you know, as we start to fall apart, sometimes giving us medicines to patch us up, but they don't usually really do that good of a job. It's an integrative approach to health. Conventional medicine picks your body apart into multiple different body systems. And so there's the nervous system, there's the brain and the psychological aspects, and nobody thinks that psychological problems have anything to do with intestinal health, have anything to do with toxin exposures, and a whole variety of things that we combine in anti-aging and restorative medicine, because we understand that, you know, as the old song goes, the knee bone's connected to the thigh bone, and the thigh bone's connected to the hip bone, and it's all connected. And by picking things apart, we're doing our patients a disservice. The other thing is we evaluate the underlying causes of disease. People don't just get sick, boom, all of a sudden a disease fell out of the sky. There were years going to the development of that chronic illness, whether it's cancer, Alzheimer's disease, or cardiovascular disease. And we have, through the study of long-lived populations around the world, through animal studies and through human studies, have been able to determine what causes the decline that happens with aging, and we are able to take steps to correct it. So some of the things we use are hormones. We do hormone restoration and balancing. We use supplements, and we use lifestyle recommendations regarding diet and exercise. And I was especially motivated when I first heard about this field because I was heading for 60 years old, had some health problems of my own, and could begin to see the unwinding of that decline that happens as you get older. Worries about my children, and were they going to have to take care of me when I couldn't take care of myself anymore, and when was that going to happen? And when I went to my first annual American Academy of Anti-Aging Conference, really a whole new world opened up to me. And I'm a very big skeptic. I really have to see scientific evidence. So I don't just kind of take it based on people's testimonials and, you know, statements about what works. I want to see the evidence. It's kind of like show me the money. Well, for me, it's show me the statistics. And anti-aging and regenerative medicine is based on a very sound scientific foundation. So I want to give you what I'm calling a Hormones 101 crash course, because you really do need to understand something about hormones in order to understand where I'm going with the whole issue of burning mouth and burning tongue. Usually we think of hormones as something to do with reproduction, right? You know, girls go through puberty, boys go through puberty. We know it has something to do with hormones, and then women get pregnant. We know that's more hormones, and then women go through menopause, and that's something more with hormones. And then men go through hormone changes, although they're more subtle and not as, you know, stark as menopause, with that abrupt cessation of two really important hormones, estrogen and progesterone. But we all do go through hormone decline as we age. But hormones have much more to do with other things in our bodies than simply reproduction. So hormones control the aging process. They control our mood. They control how much energy we have. They control our response to stress. They are really the great commanders that affect our metabolism, our immunity, our neurological function, our body temperature, our salt and water balance, all of these being metabolic activities. When we do a hormone restoration program in anti-aging medicine, we're generally working with 6 to 8 different hormones. Most of them are steroid hormones, which means they have a certain chemical structure. Estrogen, progesterone, testosterone, DHEA, which stands for dehydroepiandrosterone, and pregnenolone are known steroid hormones. Vitamin D is in fact not a vitamin. Vitamin D is a steroid hormone. It's one that we manufacture from the sun and gets produced in our skin with exposure to sun. Vitamin D has a steroid chemical pattern. And then we work with 2 non-steroidal hormones, thyroid hormone and melatonin. So these are the things when people come to see me as a patient, they have a variety of problems: fatigue, low energy, weight, no sex drive, depressed, anxious. These are the hormones that we work with, replenishing back to youthful levels. Generally, people are hormonally at their most optimal when they're between about 25 and 30 years of age. And then we start to have hormone decline from there. Stress affects hormones. Toxins in the environment affect hormones, aging, and then these reproductive processes like pregnancy and menopause. This is what the steroid structure looks like. So all of the things that you saw listed here on the left-hand side of the page have this similar chemical structure with different side groups. As I mentioned, hormones decline with increasing age. So aside from the menopause transition, men and women have gradually decreasing levels of testosterone and DHEA as they age. By the time we're in our mid-40s, which that's not very old, especially from my perspective, your DHEA level is half of what it was when you were in your 20s. And considering that DHEA is responsible for energy, immunity, muscle building, and good moods, you can see what we're working with as we get older. And testosterone declines as well. Hormones change because of stress, and I know this is a somewhat complicated slide, but if you follow the red line between pregnenolone and cortisol, you can see what your main stress hormone response is, and it's the manufacture of cortisol when your body thinks it's under a life-threatening stress. And we are certainly chromosomally and genetically the same as when we came about 10 million years ago. Our stress at that time and after that in prehistoric times was basically the stresses that animals encounter when they're out in the jungle or the forest and they're worried about predators. So our stress response was designed to save us from predators. And a number of things happen when we think a lion is going to come and bite us or want to eat us. We have a number of hormonal changes that go on. The main one being the diversion of all of our other hormones to the manufacture of cortisol. And cortisol has a number of life-saving actions. It shuts down all of your digestion. It closes down your blood vessels so that if you get bitten, you don't bleed as much. And it diverts and creates the manufacture rapidly of sugar to feed your muscles and your brain, because if you are faced with a predator, you want to get the heck out of there, right? So you're going to be running or climbing. And so our entire stress response was built on this very ancient type of stress and response to stress. Well, when you work for a boss that's stressing you out day in and day out, your body, in fact, doesn't know the difference between whether a predator is going to eat you or whether your boss is threatening you with, a bad job performance review or, more work to do. Your body has the same response, and that response ends up really being detrimental in a number of ways when it goes on chronically day in and day out. For one thing, it diverts the production of these very important, what we call feel-good hormones like estrogen, testosterone, DHEA, and pregnenolone. And then there's the hormone decline that happens with women in menopause. It starts happening in your mid-30s for women. Progesterone levels start to become erratic. Then eventually estrogen levels decline, and then eventually both estrogen and progesterone are virtually non-existent. So hormones decline, just to summarize, due to natural aging changes, due to stress, and due to changes with the reproductive cycle. But cortisol increases with age and with stress, and we'll talk later about some of the damaging effects of cortisol, because this has to do, I know you're probably thinking, what has this got to do with burning mouth and burning tongue? But it is connected, and I'll show you how. So I feel like I came to my understanding of burning mouth syndrome kind of by a backdoor approach. The first patient that I encountered with burning mouth syndrome was one of my very early patients in my anti-aging and restorative medicine practice, Her name was Jan, and she was a fitness professional, and she gave me this testimonial, and she said, I noticed my increased muscle definition after just 2 months on my hormone program. I'm sleeping better, my burning tongue is not nearly as bad, my mood swings are not as intense, I feel great. And so she gave me this testimonial, and I put it on my website, and I have to say, honestly, the burning mouth part of it did not sink in at that time. I just was a little bit clueless, but I put it on the website anyway. And then somebody got in touch with me and said, you know, I saw this on your website, and I have burning mouth syndrome, and can you help me? And so at that point, I decided I better find out what burning mouth syndrome was. And so I began researching and used PubMed and did literature searches on hormones and burning mouth syndrome, read a lot of articles, did a tremendous amount of reading scientifically, and this is where we've come to. So while I was doing this scientific research, it actually was on a 4th of July in 2011, I came across some literature about burning mouth and burning tongue that mentioned something called neuroactive steroids. And I thought, well, that sounds kind of interesting. Now that might have something to do with why these women who are on a steroid replenishment program are feeling better. And so as I was researching, I found, actually there was a doctor in France, his name is Dr. Alan Woda, and he was the main one that talked about neuroactive steroids and the effects of stress in menopausal women and their connection to burning mouth syndrome. So thank goodness for the World Wide Web. In his article on PubMed, you can get the main author on an article, they give you a link to their email. And I thought, well, I'll give it a shot. So I emailed Dr. Woda and thought, gosh, I don't know if I'll ever hear from him. It'd be really nice. I'd like to know more about this whole issue of steroid hormones and burning mouth syndrome. And 4 hours later, I got an email back. And I told him I was an anti-aging doctor, and I had observed this improvement on women with burning mouth syndrome. And what, could he help me out with trying to figure out what was benefiting them, and so that we could understand burning mouth syndrome better. And he wrote me back and said, to say that I am interested by your proposal is an understatement. It is what I was expecting for so long. I've been trying several hormone treatments, either local or systemic, and I've had some very impressive results on a few occasions, but I could never reproduce them in other women. And then he sent me a paper that had not yet been published, but which had a lot of good information for me. So I knew, as they say, that I had hit pay dirt, because I could see that the whole issue of neurological function and hormones is a huge one. And it is important not only for the millions of people that have burning mouth and burning tongue, it's important for each and every one of us, because it has to do with our memory, neurological function, and risk for Alzheimer's disease and other neurological problems. This is from your dental literature, the International Journal of Oral Science. Most clinicians dread seeing the patient presenting with a primary complaint of a burning pain. Why? And I've talked to some of you before the session started. Because nobody knows what to do with them. And none of us want to feel like failures in caring for patients, right? We want to feel successful. We want people to feel better. And when we can't help them feel better, we feel like we're letting them down. The patient with a complaint of a burning sensation of the oral mucosa presents one of the most difficult challenges to the care professional. And it's defined as a burning sensation for which no dental or medical cause can be found. There are a number of terms for it. I'm not going to bore you with it. I think we all know what we're talking about. And the symptoms are a feeling of having your mouth be scalded or burned, as if you drank something that was too hot, only the feeling continues. It can be daily and deep burning. It can be constant intensity or increases the day goes on. I've had people where it varies from day to day or month to month. The intensity is moderate to severe, similar to toothache, and I think you as dental professionals would know that's significant pain. It may improve with eating or drinking. A lot of the people I spoke to had problems with taste, and we'll get into that a little later. In some people, it interferes with sleep. You are in the position as of dental professionals, because this is happening in the mouth, people are coming to see you. But I will get into later about why that may be a little unfair, because it really is a neurological problem. It happens to manifest in the mouth. Associated symptoms are altered taste, and I've talked to people who either feel like they're eating cardboard when they eat food, or everything tastes metallic. Some people describe a feeling of washcloth in the mouth. Some people have decreased salivation, although it's not clear that that's a routine accompaniment to this. Some people feel like their salivation's decreased, but in fact, when it's measured, it's not. Some people have excessive salivation. They frequently have anxiety or depressive disorders, stress disorder, post-traumatic stress syndrome, and sometimes cancer phobia. And I want to really address the issues of these emotional components, because quite unfairly, since there's nothing that can be seen, right? There's not a lesion that you can pinpoint, there's not a test for it, it's been blamed the victim, and people have been accused of it's all in your head. But we don't see anything, where else can it be? It's got to be mental. The symptoms are often in more than one site, very typically though the anterior 2/3 of the tongue, the anterior hard palate, and the mucosa of the lower lip. When I started really questioning people with it, it has ramifications far beyond the mouth. And I've spoken to people. The first patient, Jan, that I mentioned to you, actually had burning skin on her back and shoulders in addition to her burning mouth syndrome. I've spoken to people with esophageal burning of the nasal passages, and burning eyes, and excessive tearing, and all the way down into the chest and the bronchial tree. So it involves surfaces far beyond the mouth. For some people, they wake up one morning and have burning mouth, and it seems to come from nowhere. Other people notice that it comes on gradually. It'll start with the tip of the tongue and then eventually spread to more areas. About 1/3 of patients related their symptoms to something going on, dental work they've had done, a medication they've started, an illness. And I'm not sure if it's coincidental or a real connection. And those of you who have treated these patients know that they've made the rounds of everyone who has anything to do with the mouth. Allergists, ear, nose, and throat specialists, oral surgeons, family practice, alternative practitioners. On the average, it takes almost 3 years to diagnose somebody. It's that long until somebody finally makes the diagnosis of exclusion. One of the patients I talked to, actually, the second practitioner she saw just 3 months into her problem, or 6 months into her problem, said, I know what you've got, but I don't know what to do about it. So the people who have the benefit of getting diagnosed early are left with the problem of no one knows how to help them. And people spend thousands and thousands of dollars trying to relieve these symptoms. I want to tell you a little bit, give you a few short case histories here, the people I've talked to, and they may be reminiscent of the people that you have worked with. One was a 54-year-old menopausal woman whose burning tongue began the year of her menopause in 2005. She had a tongue biopsy, it was negative. She also had burning skin all over her body, and she had been on Percocet, Valium, oxycodone, and Xanax without relief. There was a gentleman I spoke to, although that's far less common. He was 64 years old. He had had burning in his mouth for 10 months, and in addition to tongue burning, he had a metallic taste in his mouth that prevented him from being able to taste food. His throat was sore, his voice was rough, his lips and nose were involved, he had burning in his eyes, he found it difficult to swallow. He had seen an oral surgeon, a holistic doctor, acupuncturist, and had been treated with chelation, minerals, and vitamins. And then one of the most touching people I spoke to was a 74-year-old woman with many years of burning mouth syndrome who also had developed breast cancer. And she said evaluation and treatment for her breast cancer was, quote, nothing compared to what I've gone through with burning mouth syndrome, unquote. Some people say there's spontaneous recovery after about 6 or 7 years, probably in a small percentage, relatively, of patients. When recovery happens, it seems that instead of the symptoms being as continuous, they then become more intermittent. But in fact, there have been very few studies that support patients having relief of this without some intervention. So this is one of the important questions, is who gets burning mouth syndrome? 90% are perimenopausal or menopausal, and it's estimated to be anywhere from 0.7 to 4.5% of the population. The incidence increases with increasing age. And depending on whose study you look at, the ratio of men to women is anywhere from 3 or as many as 20 women to 1 man who has this problem. It's estimated anywhere from 18 to 80%, which I honestly think is a high number, but anyhow, it was in one of the studies, of women whose ovaries have been removed have some sort of mouth pain. The average age is, for females, is age 60 of the people, the age of getting burning mouth syndrome. For men, it's older, and it's very rare under age 30 in females and rare under age 40 in males. So you can see it's much more predominantly older women that get burning mouth syndrome. So I want to spend a little time talking about diagnosing it. I think this is probably fairly routine, education that you get. And I don't want to spend a lot of time on it because I want to get to the part that you probably are not familiar with. And we're going to go through these different potential etiologies and really hone in on the last 3. So the question is, are there local factors going on in the mouth that would be causing it? Things like a rough prosthesis or a contact hypersensitivity to some dental materials, or oral candidiasis or lichen planus and other mucosal disorders. So you want to exclude these, and that's, I think, fairly obvious. Possibly allergies to foods and additives to things that people are using in rinses, cheek biting and gastrointestinal reflux. I can tell you, as far as my reading and research, these are things I pulled out of some of the papers. I don't think that they really amount to much in terms of really people who have burning mouth syndrome. I think that those are rarely the causes. So then we look at systemic factors. Nutritional deficiencies, particularly B vitamins and zinc, can affect neurological functioning. If you buy that this is a neuropathic disorder, yes, these nutritional deficiencies can certainly exacerbate them. There's Sjogren's syndrome with true xerostomia. Some medications are thought to possibly cause burning mouth and burning tongue syndrome, so you want to keep this list of medications, particularly the ACE inhibitors, the acetylcholinesterase inhibitors, like lisinopril and captopril. And then diabetics have neuropathies, generally though not in the mouth. They get neuropathies that affect their peripheral, arms and legs and intestinal tract. And when these systemic and local factors were actually studied, they really were not found to be significant. So now looking at dry mouth and what's the role of dry mouth. Dry mouth is probably not the cause of burning mouth syndrome. In fact, when salivary flow rates have been measured, they, for the most part, were not found to be decreased. Although, like I said, some people feel that their salivary flow is decreased. So there's a sensation of decreased saliva, not really able to be measured, in fact. And then there seem to be alterations in some of the salivary components. And I'm quite honestly not sure what to make of this. It may be the result of some of the neurological problems that are going on. What about taste? Is changes in taste, could that be an etiology? And there's frequent reporting that people have a metallic taste in their mouth. Changes in taste are seen in as many as 2/3 of patients with burning mouth syndrome. And they seem to have a decreased intensity rating for salty and sweet test solutions. And I don't know if this is relevant or not, but Women at menopause tend to lose some of their bitter taste sensation. It does not seem to correlate with burning mouth syndrome, however. So we start looking at psychological. Like the things I mentioned: anxiety, depression, somatization disorder, and cancer phobia. Depression and anxiety exists in more than 50% of burning mouth syndrome patients compared to age-matched controls. But the incidence is very similar to other chronic pain syndromes. Chronic pain syndromes make people depressed and anxious. This was a study that was done in 2009, and it looked at 82 women with burning mouth syndrome. They compared it to a group of 82 women who didn't have burning mouth syndrome, and they saw more depression, more tongue thrusting and lip sucking, increased periodontal disease, and more smoking in the burning mouth syndrome group. And certainly smoking, we all advise our patients to stop smoking, particularly I'm sure if you're in the dental field. But again, I don't think that that accounts for most of what's going on with people with burning mouth syndrome. And the result of their study concluded, really not based on anything, was that this was of psychological origin, and that you just had to get these people to stop sucking their lips and thrusting their tongue, and and you could prevent it. So again, it was a blame the victim. And then I started looking at studies in hormones. And it seems like a logical place to go if 90% of the people that have this problem are menopausal women, and we know that it rarely occurs in younger people, and we know that there are tremendous hormone changes that occur in menopause. So I started looking for studies, and I searched on PubMed for everything, an advanced search correlating burning mouth syndrome with estrogen. And throughout all of PubMed, there were 20 citations. Most of them were review studies. There were only really 4 studies using estrogen. So you can see there's very little research that's been done into the issue of burning mouth syndrome and use of estrogen, or replenishment of estrogen, or decline in estrogen, in spite of the fact that 90% of the people who have this condition are menopausal women. So I looked at the studies, and mostly they're old studies. I mean, no one has looked at this. Only one study has been since 2000. So this is one from 1989, and they looked at 50 premenopausal women, 52 menopausal women, and who were treated for menopause with hormone replacement, and 47 untreated menopausal women. And when they looked at people's, what their percent was of having any type of oral discomfort, the premenopausal women, as you'd expect, they were hormonally repleted. Only 6% had any oral discomfort. But of the peri and postmenopausal women, 43% had oral discomfort. They also found that the group with oral discomfort had more depression and less ability to cope in life, and the group without discomfort had less depression and better ability to cope. You know, what I said about chronic pain syndromes, they wear people down, they make them depressed, they make them stressed. So after 2 months of hormone replacement in the oral discomfort group, they found, guess what? There was less depression, more ability to cope, and 2/3 experienced decreased oral discomfort. And we see this in anti-aging and restorative medicine all the time. When I have perimenopausal and menopausal women come in to see me and tell me that their moods are low and that they're having depression, or that they have always had some anxiety, but now they're getting full-blown panic attacks. What happens when we restore their hormones? I don't give them antidepressants, I don't give them Valium. We replenish hormones, and these symptoms resolve. So hormones are very connected, we know, to mood and mood disorders. So 2/3 of these women with oral discomfort got better on a hormone replacement regimen. And this from 1975, gosh, it's almost 40 years ago. Somebody took estrone gel, and estrone is one of our estrogens. Women have 3 estrogens: estradiol, estriol, and estrone. And estrone is one of the weaker estrogens. I'm not sure why they picked this one. But put it in a gel and put it on the tongue. And then they took estrone with progesterone and made a gel and had women apply it to the tongue, and then they used placebo. Well, and they all worked equally well. Okay, so that was the issue of direct placement of hormones on the tongue. This was a trial from 1992. 27 women with oral discomfort. It was not placebo-controlled. They were treated with conjugated estrogen, which is also known as Premarin or pregnant mare's urine, not the best thing for humans to be on, and medroxyprogesterone acetate, which surprisingly enough is a progesterone synthetic analog, which when I talk to you later about actual progesterone, doesn't have nearly the neurological benefits of natural progesterone. But at any rate, even with horse urine estrogen and synthetic progesterone, 55% of their women with oral discomfort improved, and their cytohormonal features improved. So some of the studies did look at tongue biopsies and look at whether there were changes due to lack of estrogen. There are changes that can happen in the mouth with lack of estrogen and atrophy of the tongue mucosa, just as it happens in the vaginal mucosa linings, with which I'm so familiar. And it's been felt possibly that the women with more estrogen receptors in the mouth and tongue were the ones that possibly benefit more in terms of improvement in their cytohormonal features of their mucosal linings when they're put on estrogen. And then the most recent study was, I lied, there has been one since 2000. It was in 2001, and there is a substance called Tibolone. It's not available in the United States, it's available in Europe. And I remember hearing about Tibolone when I was practicing OBGYN, probably 20 years ago or 25 years ago, and wondering when we were going to get it here in the US, and it still hasn't happened. And Tibolone has both estrogenic, progestogenic, and androgenic actions. So it acts like estrogen, progesterone, and testosterone. And they gave it, and this was placebo-controlled, to 56 menopausal women that had burning mouth syndrome, and 88% improved after 6 months. So I really am hopeful that more research will go on along this line of pursuit. So let's talk about the neurological parts of burning mouth and burning tongue syndrome, both peripheral and central. And I know you're looking at people's mouths, but that's not the only place that this is going on. So when we look at burning mouth syndrome as a peripheral neuropathy, and this is what Dr. Woda in France really was working on, a few things are seen. Number one, there are fewer epithelial nerve fibers in about 2/3 of the people with burning tongue syndrome by biopsy. There are altered sensory threshold in about 90% of people with burning mouth syndrome, and these seem to be both small fiber and large fiber neuropathic changes. And just to refresh your memory, or maybe you don't need it refreshed, I certainly had to go on a whole new learning curve because I hadn't learned the cranial nerve since medical school like 40-some years ago. But the chorda tympani is where we get our taste of nerve fibers from. And it is from a branch of the facial nerve or cranial nerve 7. And our sensory for the tongue is from the 5th cranial nerve, or the trigeminal nerve. And one of the theories has it that there may be damage to these taste nerves via the chorda tympani. And the chorda tympani acts as an inhibitor of afferent pain fibers from the tongue to the brain. So if you're having pain fibers in your tongue, you are less likely to feel the pain if the chorda tympani is active in suppressing the transmission of those pain sensations from your tongue to your brain. And so one of the theories of burning mouth syndrome is that somehow there is danger to these damage to the taste nerves, and the chorda tympani is damaged and no longer can suppress these afferent pain nerve sensations, and we end up with a burning sensation seeming to emanate from the tongue. We, however, do see evidence of some central nervous system changes. So the chorda tympani and the cranial nerve 5 are not the only nerves that may involve. PET scanning actually shows decline in neurotransmitter function in burning mouth syndrome, PET scans of the brain. And so we think that there may be some altered signal processing in the brain in people who have burning mouth syndrome, and possibly in all neuropathic disease processes. And so I really feel that a unifying theory of burning mouth syndrome is that it's a combined psychological, neuropathic, and hormonal problem, and I'll explain to you how. And this is just a thank you to Dr. Woda, who was in the Department of Endodontic and Restorative Dentistry in France, and is now actually surprisingly no longer working on burning mouth and burning tongue syndrome. He's working on chronic fatigue syndrome, another mysterious disease. What I think happens in the vast majority of people that have burning mouth syndrome is what I call a perfect storm, a combination of psychological, hormonal, and nerve damaging events that come together and end up as burning mouth syndrome. Well, that's interesting. Good. This is a rather complicated slide. This is one of Dr. Woda's slides he was kind enough to give me. And what he's trying to show is that up at the top left, chronic anxiety, which could be from post-traumatic stress disorder, affects your adrenal glands, and as I showed you in the slide very close to the beginning in the hormone crash course, when you're stressed and you're producing a lot of cortisol, you don't produce so much DHEA, pregnenolone, and progesterone. And then on the bottom, you have menopause coming up with losing your estrogen and progesterone. And those two things end up in the middle of the slide. What we got here? The neuroprotection that you've gotten from those hormones and neuroactive steroids ends up creating first, ectopic activity, abnormal activity, eventually irreversible lesion in the small fibers, and then eventually the burning, the taste problems, and the changes in saliva composition. And I'm going to skip this one. This basically goes over the same thing, except actually there's one thing I will mention. One of the ways that neuroactive steroids act is through membrane receptors. And the GABA A receptor is one of the prime ones, and has to do with one of the very few effective treatments for burning mouth syndrome. GABA A receptors are the receptors that Valium activates, so the things that we use to sedate people for anxiety. The GABA A receptors, progesterone is a strong agonist of GABA A receptors, and this will be important later as we go over the effects of hormones on neurological function. So like I said, there are psychological factors. They may be the cause of lower hormones, they may be the result of lower hormones, but this combination of psychological factors, decreased hormones, some type of nerve damage that we still don't know why that happens, ends up resulting in somebody with burning mouth syndrome along with depression and anxiety. The unanswered question is, which came first, the chicken or the egg? Does depression and anxiety modify somebody's pain perception? We know that can happen. Is the depression and the anxiety the result of chronic pain, or do they share a common etiology? And I really feel that the last one is probably really what's happening. So I'm going to go over some of the treatments that have been based on randomized controlled trials, RCT, looked at. And so one of them is cognitive behavioral therapy, which has been used for a lot of chronic pain syndromes and does help people deal with their pain, framing their symptoms, putting it in context, and doing psychological awareness about the place of pain in their lives and trying to diminish it through psychological exercises. So that type of cognitive behavioral psychological therapy, along with alpha lipoic acid, has been somewhat effective. Alpha lipoic acid is a type of fatty-derived acid that has been found to be effective in diabetic neuropathy, quite effective. It's a nutritional supplement that it's easy to obtain, and does seem to help diabetic neuropathy, and was looked at for burning mouth syndrome, assuming it's a neuropathy. And we'll talk a little bit more about the results of those types of studies later. Antidepressants were found not to be effective. Topical clonazepam. Now, clonazepam is in the Valium family of medications, and it does activate those GABA-A receptors. And using clonazepam as an oral troche on the tongue has been found to be at least partially effective in relieving burning symptoms. And then alpha-lipoic acid along with gabapentin. And again, gabapentin is a medication that activates these GABA-A receptors. It's been found to be somewhat effective. This is one of Dr. Alan Woda's slides, and he showed that cognitive behavioral therapy partially gave relief that lasted for more than 6 months, and when it was used with alpha-lipoic acid, it got, again, some improved results, not dramatic. A little bit more about alpha-lipoic acid, which I already mentioned. It's a potent antioxidant. It helps to regenerate other antioxidants. Glutathione is one of our most potent antioxidants in our body, and it stimulates the production of nerve growth factors, which are very important. I don't know if you're aware or not. You know, for many years, the medical field felt that in terms of nerve cells, you had what you were born with, particularly in your brain, and if they, got destroyed, that was it. Remember the ads, here's your brain, and here's your brain on drugs, with the fried eggs? Well, it turns out that we're able to regenerate new nerve cells in our brain. And there are a number of factors that will help us with this regeneration. One of them is alpha-lipoic acid. It's also neuroprotective, because we're talking about trying to prevent further decline in the nerve function. It's been proven to be effective, like I said, with diabetic neuropathy, and somewhat inconsistent results when it's been studied for burning mouth syndrome. And Femiano in Italy is the main person that has looked at alpha-lipoic acid, and he got great results in 4 studies, but there was no details about blinding, recruitment, outcome, and dropout levels. And and he claimed there was improvement anywhere 76 to 90% of the cases. But when people tried to reproduce his results, they did not get the same results. So hard to say what alpha-lipoic acid is doing for people. And here's Dr. Woda's, he's confirmed this in 2 studies, they were not blinded, putting topical clonazepam on the tongue in the form of a troche and letting it melt. The good thing about it is that people don't get high blood levels from this, because one of the concerns you have about using clonazepam and drugs in the Valium family of medications is that people get addicted. And then you have 2 problems. Then they have their burning mouth syndrome, and then you're dealing with addiction problems. So he had people clonazepam 1 milligram, they sucked it for 3 minutes, didn't swallow it, spit it out, and did that 3 times a day. And that has provided partial relief for people. So, going through all of this and trying to figure out, again, what was I doing in the hormone restoration programs I had patients on that was making them feel better. And so I want to go over what these different hormones do in terms of neurological function. Well, cortisol, remember, I said goes up with age, and it goes up with stress. And it will shrink your brain. It will shrink the hippocampus, which is the memory part of your brain. High cortisol levels are neurodegenerative, and high cortisol levels impair cognitive function in humans. So cortisol certainly has adverse effect on nerves, and that may be some of the connection between the post-traumatic stress disorder that we see and the depression and anxiety that we see. Cortisol also, through inflammation, cortisol ends up being inflammatory in high amounts, is bad for nerve function. So it causes something called inflammatory neurodegeneration. Like I said, it directly affects the hippocampus. The hippocampus is where new memory gets laid down. You really don't want to shrink your hippocampus. And I don't know if you've ever noticed that when you get really stressed, it gets kind of hard to remember things sometimes. That's cortisol effects on your brain. And it makes neurons more vulnerable to excitotoxins like glutamate, things like monosodium glutamate are what's called an excitotoxin. They're excitatory to the nerve cells in your brain, and if your nerve cells get too excited, they die. So excitotoxins will kill nerve cells in your brain. That's why we recommend that you don't ingest MSG. Cortisol will increase the vulnerability of your nerve cells to excitotoxins. So what are we doing when we do a full hormone restoration program? These are the things I showed you before. These are the 8 different things that we utilize when we are restoring deficient hormones. Neuroactive steroids are a little bit different than systemic steroids, so I want to tell you a little bit about them. They're actually produced within the nerve. So your nerves in your brain are making estrogen and testosterone and DHEA all by themselves. They fluctuate in response to stress. There is a study, it seems really cruel, but they take rats and they ligate the sciatic nerve, or they crush the sciatic nerve in order to study nerve damage, and then look at what happens adding different things back to that nerve function. Does the nerve function improve, or can they protect the neurodegeneration that happens from that ligation? So neuroactive steroids, when they study them, seem to fluctuate in response to injury. And they act a little differently than steroids act in the rest of our bodies. They have a very rapid action by activating membrane receptors. Most of the time when we're talking about hormonal activation and the benefits of hormones, it's processes that take place due to activation of the chromosome inside the cell and making different messenger RNA and different RNA and eventually different proteins. This is a very rapid response that happens with just activity in the membrane, so it's extremely rapid. The other thing about neuroactive steroids, they cross the blood-brain barrier. They cross in both directions. So steroids that we give people go to the brain, steroids that are made in the brain come to the systemic nervous system. They're affected by psychotropic medications. We talked about Valium and clonazepam. They act via GABA and other receptors. Neuroactive steroids are neuroprotective and neurotrophic. So neurotrophic, it's like Miracle-Gro for your nerves. It nourishes your nerves and helps them grow. Inducing neuroplasticity, meaning that nerves are more resilient to damage, and increasing myelin formation and inducing dendritic and axonal growth, and I'll show you some parts of the nerves. These are the neuroactive steroids, and these are the things that we use in hormone restoration. We use pregnenolone, DHEA. Progesterone has 2 very potent metabolites, allopregnenolone and tetrahydrodeoxycorticosterone, and those 2 metabolites are just like Miracle-Gro on steroids for the brain. We see progesterone when we replace it in women. Progesterone is like nature's Valium. It's a very safe way to calm the brain. It's a very safe way to improve neurological functioning. And testosterone, estrogen, and vitamin D all have benefits on nerves, and we'll talk about them one by one. Pregnenolone I already mentioned in terms of your memory. It enhances maturation of the synapses, which are the places where one nerve communicates with another. The metabolites of pregnenolone are neuroprotective. The metabolites of pregnenolone are 17-hydroxyprogesterone, progesterone, and then on down the cascade to estrogen, testosterone, DHEA. And the metabolites of pregnenolone decrease the sensitivity to painful messages following peripheral nerve injury. So when you have pregnenolone and its metabolites and you create a nerve injury, the pain sensation is decreased. DHEA is another major neuroprotective agent. Again, after these nerve transections in rats, it decreases neuronal damage. And higher levels of DHEA are associated with higher nerve growth factor in humans. People with Alzheimer's disease are found to have lower DHEA levels than people without Alzheimer's disease. So very possibly there is a protective effect in terms of maintaining nerve growth. Yeah, I already went over this. There was a study with DHEA that was done with 30 patients with VMS and 30 controls, and it turns out people with burning mouth syndrome had lower salivary DHEA levels, as well as more problems with taste and low amounts of saliva than control subjects. So looking at progesterone, and this is really where a tremendous amount of implementation needs to be done. Progesterone is a potent anti-inflammatory and anti-apoptotic agent. Apoptosis is programmed cell death. It reduces damage after traumatic brain injury in rats. And more importantly, when humans with traumatic brain injury are given progesterone within 72 hours of the injury, they not only have lower amounts of neurological and brain damage as a result that can be measured on imaging, they in fact have much improved functional outcomes. So this for me was a huge bit of evidence in terms of the importance of progesterone in neurological function. And I'm lobbying to get progesterone, you know, on the football field and the battlefield where people get brain injuries and get head injuries and traumatic brain injuries, because they need to be getting progesterone within 72 hours in order to preserve as much brain function as possible. Progesterone decreases diabetic neuropathy in rats, and post-stroke induced strokes in rats, there's better neurological outcomes. So progesterone and its metabolites are really key in maintaining neurological function when there's neurological damage. Allopregnanolone is one of these metabolites. It has analgesic effects, meaning pain-killing effects. It's neuroprotective, so it protects nerves against damage. And we also see that it is an antidepressant and anti-anxiety agent, which I mentioned before, and that's something I've observed over and over clinically. They have used synthetic analogs, and people are always, you know, pharmaceutical companies are always looking for synthetic analogs because they can't patent the natural product. So you can use natural progesterone, you can use natural allopregnanolone, but you're not going to make $1 million doing it, so you want to find a synthetic analog. And to my disappointment, that was what I have seen through all the neuroimmunoendocrinology literature, is the searching for the pharmaceutical agent that will do what we already have does excellently. Anyhow, they're looking for synthetic analogs, and found when they found them, they found that there was pain-reducing properties when used. In the central nervous system, allopregnanolone increases endorphins and opiate receptors, which are natural pain-relieving substances. And allopregnanolone may help with maintaining regenerative ability in the brain and modifying progression of Alzheimer's. It's something being studied now. Testosterone as well may have a role in neurodegenerative diseases. We see that depletion of testosterone leads to functional impairments and increased disease risk in the brain, and that testosterone may play a role in development of Alzheimer's, that is low testosterone levels. Estrogen, we see altering the excitability of the afferent fibers, these pain fibers and sensory neurons, to Knox's stimulation of craniofacial tissues. That means when women are on estrogen, they don't feel the pain as much when there's noxious stimulation of tissues around the face and mouth. Estrogen also helps to prevent neuronal cell death by maintaining mitochondrial function. You know, mitochondria are the little energy packets in our cells, and one of the reasons that we undergo decline with aging is that we lose mitochondrial function. So if you can maintain mitochondrial function, you maintain cell viability. And estrogen also protects and regenerates peripheral nerves, and it induces the neuroactive steroid, neuroprogesterone, in the astrocytes. And the astrocytes are the cells in the brain that are the most active neurosteroid-producing cells in the entire central nervous system. The things that we see with lack of estrogen, there have been studies showing that women who have their ovaries removed lose 15% of their brain processing speed. Clearly, estrogen has tremendous neurological effects, and it seems to be a critical survival and nerve-sparing growth and protective factor in the substantia nigra in the brain, which has to do with part of the brain responsible for Parkinson's disease. We know that there is tremendous benefit of hormones in prevention of Parkinson's. Estrogen also modulates the stress response. There is not as much cortisol produced, not as big a spike in premenopausal women who have their estrogen competition. And so estrogen helps to modulate that stress response. You don't get as much cortisol produced. You don't get as much presumed neurological damage as when you have adequate estrogen. Estrogen also supports mood by supporting serotonin, which is one of our important neurochemicals that prevents depression. And then talking about vitamin D, like I told you, it is really a steroid in disguise, masking itself, masquerading as a vitamin. Vitamin D also helps neurotrophic factors. It's more a miracle grow for your nerve cells. Enhances glutathione, and glutathione is a very potent antioxidant that helps maintain the health of our cells. So it has, we know, potential in treating neurodegenerative and neuroimmune disorders, and it's being studied currently for that. And then what about the non-steroids? Even melatonin, we see stimulates peripheral nerve regeneration because of its very potent antioxidant properties. And thyroid, which has been studied, and I want to show you a study in just a minute, it increases BDNF, brain-derived neurotrophic factor, which is very important to maintaining the health of your brain cells and preventing things like Alzheimer's disease. And triiodothyronine, which is our active form of thyroid, has similar protective effect on brain cells as studied in an experimental model of traumatic brain injury as progesterone, which is very potent. So there was a study done, and there's been some debate about thyroid and burning mouth syndrome. And there's one school of thought that says if somebody has a thyroid problem and it corrects their burning mouth syndrome, then they didn't really have burning mouth syndrome. So I'm not going to get into that debate because I think it's really not to the point of how do we help these people get better. So a study that was done in 2008 by Femiano, he evaluated the role of low thyroid with oral burning disorders. And by eliminating those with low thyroid function, they, again, like I said, were trying to find those that they said had primary burning mouth syndrome. And they did this case control study, 123 with burning mouth syndrome and 123 without. Of the group with burning mouth syndrome, 58 they called hypothyroid. They didn't really define what they meant by hypothyroid, so that was a little bit unclear. And in the group without oral burning, 13 were hypothyroid. The people who were defined as hypothyroid, when they got thyroid replacement, 64% of them had resolution of their symptoms, which is huge. And 38 of the 38 who had normal thyroid that they did not treat with thyroid medication, they had about a 10% improvement with alpha-lipoic acid. What this says to me is that thyroid might be part of what is going on that is improving people that I've witnessed clinically. So I want to tell you a little bit about what I've seen clinically. I have a database of 112 private patients. 107 are female, 5 are male. I was an OBGYN originally, and so my practice tends to be largely women. And in this practice, I've seen 6 perimenopausal and menopausal women with burning mouth syndrome that have had their symptoms anywhere from months to years. All of them are on a hormone restoration program with the things that I already described to you. In all but one person, their symptoms completely resolved. That was 83%, and it took anywhere from 1 to 4 months for their symptoms to resolve. One of the patients, the one who was my very first patient with burning mouth syndrome that I mentioned at the beginning, had a recurrence during a time of severe stress. She was getting divorced, and even though she was on her hormone restoration program, her burning tongue returned. She, however, had good success at that point with alpha-lipoic acid. So you can see the stress hormone connection and how it affects burning mouth really, very graphically with her. So when I saw that a lot of women felt better who had burning mouth syndrome when they were on a full hormone restoration program as my private patient, I tried to figure out what could I put together that people could get who did not come to see me as a private patient, either because of financial reasons or they live too far away. And a lot of the hormones are prescription, and so I can't prescribe somebody that's not a patient. And I pulled out things that I knew were very important in terms of neurological functioning that could be used as a nutritional supplement. So DHEA and pregnenolone, although they're potent hormones, they're available as nutritional supplements. They have not been categorized as medications that require a prescription. Vitamin D, of course, is available as a nutritional supplement. And I also added alpha-lipoic acid to the mix because it's unclear whether it has benefit or not. I thought I would put it in there, and I put it into a supplement and did a small pilot study with it. I had 11 subjects who had burning mouth and burning tongue. There were 10 women and 1 man. And their symptoms, one of them had very short duration of symptoms, so I don't think that really counts. Some of them had had symptoms as long as 12 years, and they served as their own controls. I was not in a position to do a full double-blinded randomized control study, and part of what I'm going to ask you, if any of you here are in academics and in a position to help that happen, I really would like to know. So we did the supplement kit that had the items that I mentioned, DHEA, pregnenolone, alpha-lipoic acid, and vitamin D. And I gave people a symptom questionnaire asking them the location of their symptoms, the severity of their symptoms, and the variety of their symptoms. So we asked about the variety and severity of pain, burning, whether it interfered with sleep, whether they felt they had excess salivating, any dry mouth, or altered taste. I asked where their symptoms happened, because in my observation, it often goes beyond the mouth, beyond the oral cavity. And the results we got in terms of symptoms, and we did a pain score, 0 to 10, 10 being the worst, 0 being no pain at all. On average, the symptoms of pain prior to using the supplement was 7 on a 10-point scale and reduced to 3.4 afterwards. The burning part was 7.8 on a 10-point scale, reduced to 3.6. Preventing sleep occurred was a problem for about half the patients, and the score was 4.8 on a 10-point scale, reduced slightly. Excess salivating, 5.2 out of 10, reduced slightly. Dry mouth, 4.8 on a scale of 10, reduced slightly. And altered taste, 6.7 on a 10-point scale, reduced to 4.9. Looking at it overall, 8 subjects felt significantly better. 2 subjects had resolution of their symptoms. In 2 people, there were no change at all. And 1 person actually got improvement, but these supplements in the compounded formula made her so hyper she had trouble sleeping, and so she couldn't continue to take it. So what I want to do is conclude and then have some time for questions. So the one thing I hope I've gotten across to you is that this is a neuropathic pain syndrome that's exacerbated by deficiencies in both neuroactive and systemic steroids. These steroid deficiencies could be the underlying cause of the depression and anxiety that we so frequently see in burning mouth syndrome. That treatment with hormones likely replenishes systemic steroids, that I know, likely replenishes neuroactive steroids, and has the potential to provide relief for patients with burning mouth and burning tongue syndrome. Given the large number of people with burning mouth syndrome, and it is many millions worldwide, it's really essential that further studies be done to examine the role of neuroactive steroids and systemic steroids in burning mouth syndrome. And very importantly is, don't assume it's psychogenic just because you can't see anything. And when I gave this talk last year at the California Dental Association, somebody waited until everybody else had left after the talk and had asked me all their questions and came up to me. She was a dental hygienist with burning mouth syndrome, and she started crying because she said, finally somebody's realizing that it's not all in my head, that there's really something going on here. So that was really touching, and that's the most important thing, is just because we can't figure it out doesn't mean it's all in somebody's head. The other thing is looking beyond the oral cavity. I know people come to see you because you're experts in the oral cavity and that's where they're feeling it, but really looking beyond it to the whole issue of what other mucosal and skin surfaces are involved, and understanding that this is a peripheral nerve as well as a central nervous system issue. The things that are done to relieve problems in the oral cavity are helpful to people for sure, and don't stop doing those, but really looking beyond that for truly relieving the problem. And then consider referring patients to an anti-aging specialist. There are thousands of us across the country who deal with hormone replacement, and really encouraging more research into hormone solutions. It was very, it's pitiful that there were only 4 studies on estrogen in all of the literature, when this so clearly is a hormone-related issue. Anyhow, so if we can keep getting people to open wide and let us do our work, I guess we can continue on. So I'm happy to answer questions, and I do want to mention, if people are not able to access the slides and the handout, if you take one of my cards, my email is on there, and you can email me. I'd be happy to send it to you as an attachment. Do we have questions? Yes.
In your pilot studies, did you deal with the patients that did have Sjogren's syndrome? And was there any relief with your replacement therapy in those cases?
The question is about Sjogren's syndrome. The people I've dealt with.
I wonder if there was any relief with that, if they would be able to get any relief with that.
Yes. The question is right. Is hormone treatment going to help people with Sjogren's syndrome? I didn't deal with any people with Sjogren's syndrome. I was pretty much dealing only with burning mouth syndrome patients. And so I can't answer that question for you. But it's certainly something to look into. We know that in anti-aging and restorative medicine, Sjogren's is an autoimmune disorder. And again, it's an area where conventional medicine just kind of throws their hands up and says, well, I don't know why this happened. I have autoimmune disorders. One of the whole reasons I got into this field was my own autoimmune disorders. And we know that autoimmune disorders start in the intestine, believe it or not. And so we do a lot in anti-aging and restorative medicine to get at the intestinal causes, food allergies, gluten intolerance. And hormones certainly play a role in reducing inflammation with autoimmune disorders. Whether they particularly, that's something I don't know, I'd be happy to look into, whether they reduce the dry mouth and some of the other symptoms of Sjogren's, I don't know. Any other questions? Yes, over there.
2 questions. How long did you keep patients on your over-the-counter meds, your vitamin D and DHEA?
Well, how long did I keep people on the over-the-counter kit? It takes up to 3 months to see benefits. So I encourage them, I had a buy 3 for the price of 2 thing going on, to encourage people to use it for 3 months. And after that, people need to be on it indefinitely. Just like any, our hormone replacement that we do for anti-aging, if you stop your hormones, your body goes back to the hormone deficiencies that it was in before. So it's presumably something that people would need to be on long term.
Second question, do you see this burning time as a side effect to radiation therapy for cancer patients? Have you heard of that?
Right, so a question of burning mouth syndrome and radiation. I actually,
Burning time and oral, I've got 4 patients.
post-radiation. I did not work with people who contacted me that had post-radiation because it was too confounding for me to know, but I'd be happy to give you information to see if it would help them. Yes?
So the prescribed hormones, are these like identical so-called, and are they
Right, how do we do hormone restoration? Are they bioidentical? Yes, I think it's really important that the hormones we use are the same ones that your own body makes. We see improved effectiveness, fewer side effects, and the medroxyprogesterone, that was this progesterone synthetic analog used in that one study, doesn't have near the neurotrophic and neuroprotective effects of natural progesterone and its metabolites. And how the hormones are given, I tend to use progesterone in an oral form, in a pill, because it gets more breakdown into its metabolites than when we use it as a topical cream. Estrogen is used most safely as a topical cream because then you don't get the increased risk of clotting that leads to increased strokes and cardiovascular disease. And testosterone, again, we use as a topical or injection because oral testosterone has increased risk of liver cancer. So we use the various forms depending on our goals and risks and side effects. Yes, in green.
Could you tell me which product, the alpha lipoic acid you recommend? Because you have a lot of variants and supplements that are on the market. Is there a certain one you like and a dosage and frequency?
Yes. A question about which alpha lipoic acid. Yes, there's a company that makes a product called Ralapure, R-A-L-A-P-U-R-E. And it has R-lipoic acid. There's 2 isomers of lipoic acid. The L form and the R form. I think it's L, D, D and R. I'm not sure. Anyhow, there's the R form and another form. And when you get lipoic acid in nature, you get both forms. And this company has purified their lipoic acid into only being the R-lipoic acid. And I think it's more effective. I do. And people start out using, I honestly don't remember the dosage off the top of my head. He only has 1 dose in Ralapure, and you use, I think it's 3 of them 3 times a day to start, or 2-3 times a day. People need to be on quite a bit initially, and then they can taper off as they get relief of their symptoms. Not go off totally, but they don't need as intense treatment. Yes?
2 questions. We decide we need to send somebody out, hormone therapy. Would you think that most OBGYNs should be able to handle that sort of thing? It sounds like maybe not, because you used to be one, but or do you send them an endocrinologist, or what should we do to find somebody? We may not be able to find an anti-aging specialist where we live. And the second question was, are there long-term hazards of hormone replacement therapy?
Okay, two great questions. Okay, would an OBGYN or endocrinologist know how to do this? Very unlikely. I was an OBGYN for 25 years, and I worked a lot with hormones, hot flashes and testosterone in women for libido, and had absolutely no idea about the anti-aging and restorative whole side of it. So as an OBGYN and well-versed in hormones, was limited to using 3 hormones, and I thought, GYNs think if a woman's had a hysterectomy, she doesn't need to be on progesterone if she's, even though she's on estrogen, and that's absolutely not true. So the OBGYNs are not going to get you where you want to go. The endocrinologist, I've had patients come back and say the endocrinologist had signs in their office, no bioidentical hormones, we don't do that here, don't ask. So the endocrinologists are very narrowly doing diabetes and thyroid. There is our national organization, the Anti-Aging, American Academy of Anti-Aging Medicine, has a website called worldhealth.net, and there is a locator on there for doctors who do anti-aging medicine. And I also work with people remotely, so that's another option. And then as far as safety, yeah, let's get into the safety issues, because this is frequently what hangs people up from using hormones. How much time do we have? Oh, okay. There is so much out in the media about the dangers of hormones, both estrogen for women and testosterone for men, right? So estrogen is breast cancer and testosterone is prostate cancer. And you have to realize something about the media. Why does the media exist? To make money. And what are they going to publish? things that aren't sensational that will make you want to buy their publication. And so there's tons of stuff on there, and I did a research project. There's far more information in the media about the dangers of hormones than the benefits of hormones. The dangers of hormones in women largely come from concerns from the Women's Health Initiative, this very large 88,000 women study that was started in the late 90s, and came to the conclusion they did use conjugated estrogen, Premarin, the horse urine I was talking about, estrogen, and medroxyprogesterone acetate, the synthetic progesterone, and found that women had a 30% increased risk of breast cancer. And so that got widely publicized, and then they kind of narrowed it down. So that was the first splash that came out in 2002. It scared the heck out of everybody, and 2/3 of the women on hormones went off. And then as the literature and the study has unfolded, well, come to find out, really it's the medroxyprogesterone acetate. I think it should be off the market. It's carcinogenic. When you use natural progesterone with estrogen, you get no increased risk of breast cancer. And so I think the misguided use of a synthetic analog took us down a really bad pathway, and they figured out, somebody did a kind of a algorithm and figured out in the 10 years after the Women's Health Initiative, because of the non-use of hormones in women who had a hysterectomy, there were probably 50,000 unnecessary deaths from premature cardiovascular disease, because the women did not get the benefit of the hormones to preserve their cardiovascular system. So the studies that we see now, and I see in my gynecology literature, people are now backpedaling and saying, well, you know, it's not so bad, and really it's not as bad as we thought it was, and maybe for a short time, and maybe in certain subsets of women, trying to backpedal from that position of saying that it was dangerous. So estrogen even had a black box warning on the prescription. So I would say, from my perspective, if given properly, if balanced with progesterone, testosterone, and we also test how women and men metabolize their estrogen production, because some estrogen metabolites are carcinogenic and some are protective. And you can actually find out if you're metabolizing down a carcinogenic pathway and correct it. So there are lots of ways to give hormones safely, and the whole issue of testosterone and prostate cancer is something that came out of a case study in like 1948 that somehow got completely blown out of proportion, and we have, you know, huge amounts of evidence in the literature that show that testosterone does not cause prostate cancer. And there's too much to go into, but I have a number of articles. If anybody really wants to know, I can send you some information about it. So my perspective is, not only aren't hormones dangerous, that they are life-preserving and health-preserving, and we see it in so many ways. Cardiovascular, men with low testosterone are increased risk of cardiovascular disease, increased risk of Alzheimer's, and the same goes for women and low estrogen. So from my perspective, as an anti-aging and restorative medicine physician, I only see benefits and really very little in the way of any risks. Let's see, I don't know, okay, I'll take you
Do
here.
you have any studies as far as vitamin D deficiencies in African American women, as far as, because I know my mother had burning mouth syndrome.
Yes.
And I was low maybe some months back on my vitamin D.
Yes. The issue of vitamin D deficiency in dark-skinned people. Dark-skinned people do not get the amount of conversion of sunlight into vitamin D as light-skinned people, and tend to have very low vitamin D levels. So it is extremely important. Actually, everybody should get your vitamin D level checked. And don't go by what the lab says is an okay value. They'll say anything between 30 and 100 is okay. You want to be minimum 60, but more likely 80 to prevent your cardiovascular and brain function as you age. And sometimes it means taking 10,000 international units a day. Well, the guidelines are between 400 and 800 international units a day. That is not going to get you where you want to be as far as your vitamin D level. So usually it's 10,000 a day, and then you need to get rechecked after about 3 months. And if your level's up at 60 to 80, then you can be on a maintenance dose of, say, 5,000 international units a day of vitamin D3. You want D3. And there have been tons of studies. Are we running out of time? Close. There have been a ton of studies on vitamin D levels and how they correlate to disease and health. And it's clear that 60 to 80 for multiple sclerosis and other autoimmune prevention, cardiovascular, Alzheimer's, cancer prevention with vitamin D. So I can take one more question?
Sure.
Okay. Gentleman way in the back.
Two-part.
Uh-oh.
Are these kits, these home kits, are they available through?
Yes, I have them on my website. Mhm.
Okay, so that's my second question is, are you aware of any type of treatment or this hormonal efficacy in treatment of RSD or CRPS?
Reflex sympathetic dystrophy. And what was the last one?
CRPS, chronic regional pain syndrome.
I don't know.
Calcalgic pain.
Yes, I know.
Continuous
It
neural
also
pathway
has a
pain.
very high predilection in women.
Oh, wow. Well, that's a whole other field, and I will be looking into that. Yeah. There's very deep in, there's this neuro, psycho, endo, immunology literature. And so all these things may be in there, and I'll definitely start looking into it, because I think that's a whole other groups of people. Good. Well, thank you.
I don't know about y'all, but I found that very interesting, because I know, like many of you, I've had patients with burning mouth syndrome, and I've learned a lot today because I didn't know how to help them. So thank you. Thank you, Dr. Sklar. Appreciate it very much.